Obrigado. Como ontem, tenho muito prazer para falar em frente de vocês. Vou falar na inglês, é mais fácil para mim. Então, desculpa. Thank you, Dr. Botelho, again for inviting me. I may be American, but I have Irish blood. And I'm going to do, I guess, the next 2 lectures. And we have a saying in Ireland that you never let an Irishman hold the microphone for too long. So, after that great talk about the classifications, some background on thoracolumbar fractures we know are usually high energy mechanisms. They are not only injuries that involve a lot of energy and velocity and momentum, but they don't just focus on the spine itself. More than 1/3 of patients who suffer these injuries also have concomitant injuries. And most of what I talk about with decision-making for surgery, I'm going to base on the load-sharing classification system as was just described. So basically our management usually begins with the presence or absence of neurologic deficit. And this leads us towards the non-operative bracing or casting versus the different operative techniques, anterior, posterior, etc. But I think after that long discussion of how complicated this has been over the last century, I think when we really take into account what we're looking for in these injuries, it goes beyond neurologic deficit and non-neurologic deficit as to whether or not someone should have a brace or a fusion. I think there's obviously a middle area. Bracing is a poorly tolerated endeavor for multiple months and exhibits a lot of stress onto patients. There's compliance issues, and again, there's the issue of concomitant injuries and polytrauma. And I think we need to reread the studies that lead us to practice the way that we do. And this is a paper that many orthopedists use to argue that we brace patients with no neurologic deficits. But I think on closer inspection of that, we need to remember certain things. This was coconuts and mangoes. There were 3/4 or 75% of patients were smokers in the operative group, and only 1/4 were smokers in the non-operative group. This also excluded polytrauma. So somewhere in the middle, I think there is other interventions that need to be looked at. And so in my institution, we've been using pedicle screw fixation for mobilization of polytrauma patients and the avoidance of bracing. Percutaneous screws obviously provide the stability of instrumentation without disruption of the interspinous ligaments or the posterior complex. In many cases, we can spare the facet capsule, and we can see the evidence that has provided the augmentation of interbody fusions. And this is the obvious technique for placement is through a far Wiltsey type incision. I do not make midline incisions for this. The setup is very common and very easy for most people with dual fluoroscopy. Whether or not you use 1 or 2 machines is irrelevant. We published our experience with several thousand screws that we've placed, and really there's almost 0% misplacement when you get into direct angulation. So basically above L4, it's I don't want to say it's hard, but it's a fairly easy procedure to place with great accuracy. So in the beginning, we had the concerns, obviously, of how much stability could be administered through this procedure. And this is an early example of a 42-year-old female who was horseback riding, suffered an L1 burst fracture with no neurologic deficits, had difficulty tolerating any bracing, minimal canal compromise, and in 45 minutes, she was able to have the implants placed. Truth be told, 2 years later, she did want the implants out, but was doing extremely well. And I think with the mounted evidence from the same group discussing the load-sharing classification system, that short segment instrumentation with or without anterior can provide great stability. So now this is a T10 vertebral fracture of a fall of a worker. But there's minimal comminution, good fragments that are fairly opposed. He is obese. He's also kyphotic, and so tolerates a brace very poorly. This, again, is a 40-minute procedure, and he's able to mobilize for other testing. Similarly, 61-year-old male with involvement of the pedicles and easily stabilized, minimal loss of height at 2 years. Another consideration, as I had just mentioned, is that you can instrument the fracture site itself, providing increased stability. Again, this is data from open procedures where implant failure is decreased, or was decreased in this scenario, with inclusion of the fracture site itself. This is a case actually just from last week. This is a 67-year-old male who had a ton of bricks dropped on his head at work. He suffered a brain injury, however, was cleared. He needed stabilization for concomitant upper extremity fractures. He had minimal canal compromise, and he underwent 3-level instrumentation. Do this through stab incisions. Again, you can see the body habitus of the patient. He's, again, obese. This is an American phenomenon. And would not tolerate a brace very well. Here he's standing 4 days out. So we recently published our short segment fixation patients over the last 6 years in orthopedics. And what we point out with this is, though there was no neurologic injury, 11 of the 32 patients required secondary procedures in the hospital. Those were operative interventions for varying systems, whether or not they were orthopedic injuries, cranial injuries. What I would point out is the remainder of those patients, the other 21, also needed to be mobilized for MRIs, for other testing. And doing so, mobilizing a patient in a brace, we all know that that can be a big strain on the system. So our long-term data, we were able to look at the fact that the short segment instrumentation, as you've seen, 1 level above, 1 level below for these unstable burst fractures of a load-sharing classification, up to 6, and several of them were 7s. We're able to maintain the overall anterior and posterior height at 2 years, as well as the angular kyphosis was able to be maintained over that time as well. That series had no infections, no misplaced hardwares, and no neurologic deficits caused iatrogenically. So this is a 58-year-old male, status post-motor vehicle accident. Again, he's obese. He also has a fracture dislocation of his ankle, pelvic injuries, an acetabular fracture, and pelvic wing injury requiring open reduction fixation, and underwent, again, 45-minute procedure to be mobilized for other procedures requiring significant intervention and blood loss, etc., while maintaining any lack of blood loss during the procedure itself.